Welcome to Board Pearls. This is episode 5 of 5 of the Hereditary GI Cancer Syndromes chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover hereditary pancreatic cancer and the multi-organ coordination of cascade testing, the CAPS protocol applying EUS and MRI surveillance to BRCA2, PALB2, ATM, CDKN2A, PRSS1, and familial pancreatic cancer kindreds, and the multi-organ coordination of cascade testing and genetic counseling that ties together every hereditary GI cancer syndrome at the family systems level. Roughly 10 to 15% of pancreatic ductal adenocarcinoma carries an identifiable germline mutation, and the genes cluster into two mechanistic families. One family is the homologous recombination repair pathway. BRCA1, BRCA2, PALB2, and ATM all encode proteins that participate in fixing double-strand DNA breaks through high-fidelity repair. The other family is direct pancreatic susceptibility. CDKN2A removes the brake on the cell cycle. STK11 dysregulates mTOR. PRSS1 drives recurrent acinar injury, and the mismatch repair genes of Lynch produce microsatellite instability throughout the genome, including in the pancreas. Familial pancreatic cancer kindreds are families with two or more first-degree relatives affected by pancreatic cancer, regardless of which gene is identified. The relative risk rises steeply with the number of affected first-degree relatives. The clinical task is to decide which of these carriers actually enters surveillance, and that decision is the most testable concept in this section. The gating principle is calibration to absolute lifetime pancreatic cancer risk rather than to relative risk. The threshold above which surveillance benefit outweighs harms sits at approximately 5% absolute lifetime risk. Below that threshold, the false positive workups, the procedural complications of EUS, and the anxiety from indeterminate cysts collectively outweigh the rare cancer detection. Above that threshold, the math reverses. The CAPS Consortium and the AGA Expert Review build the eligibility list on this principle. That principle splits the genes into two groups. Some carriers cross the threshold on the gene alone. STK11 carriers from Poitzschegers have a relative risk on the order of 130, which puts absolute lifetime risk well above 5% without any family history. CDKN2A carriers in the familial atypical multiple mole melanoma kindreds carry relative risk roughly 13 to 39, and PRSS1 carriers from hereditary pancreatitis carry standardized incidence ratios near 50. These three syndromes, plus the familial pancreatic cancer kindreds, qualify for surveillance on the genotype or pedigree alone. The other group falls below the threshold on the gene alone. BRCA1, BRCA2, ATM, PALB2, and Lynch carriers have relative risks in the range of 2 to 11, which is not enough to push absolute risk above 5% without an additional driver. That additional driver is family history. These carriers enter surveillance only when there is at least one first-degree or second-degree relative with pancreatic cancer in the pedigree. The single most common board question on this section is dressed as an asymptomatic BRCA2 carrier with no family history of pancreatic cancer. The question is whether she should enroll in annual EUS, and the answer is no on the gene alone. The starting ages follow the same logic. STK11 starts at 30 to 35 because pancreatic tumors emerge in the 30s and 40s under STK11 loss. CDKN2A and PRSS1 start at 40 because the pancreatic cancer onset distribution under those genes is centered later than Poitzschegers. BRCA1, BRCA2, ATM, PALB2, and Lynch start at 50, or 10 years before the earliest pancreatic cancer in the family, whichever is younger. The 10 years before rule is the same shift used in Lynch colorectal surveillance and in attenuated FAP, and it accounts for the families whose phenotype clusters at younger than typical onset. The surveillance modality is annual EUS or pancreatic protocol MRI with MRCP, and most consensus protocols alternate the two every 12 months. The reason for alternating is that the modalities are complementary rather than interchangeable. EUS detects solid lesions exquisitely, allows fine needle aspiration of suspicious findings in the same session, and characterizes parenchymal changes, including the lobularity and hyperechoic strands that accumulate in high-risk pancreata. MRI with MRCP is superior for cyst surveillance and for visualization of the pancreatic ductal anatomy, and it avoids the procedural risk of repeated EUS. Detection of a new pancreatic cyst, a solid lesion, or main pancreatic duct dilation triggers EUS-guided sampling and multidisciplinary review. The detailed cyst thresholds and the surgical referral pathways live in the pancreas chapter. What travels with the listener for this section is the rule that high-grade dysplasia and stage 1 pancreatic adenocarcinoma are detectable in screened high-risk carriers in the formal cohort programs. Absolute survival benefit relative to symptomatic detection remains under active study. Hereditary pancreatitis driven by germline PRSS1 mutations deserves its own paragraph because the numbers are so different from the rest of the list. PRSS1 encodes cationic trypsinogen, and the gain-of-function mutations produce trypsin that resists deactivation inside the acinar cell. Recurrent intracellular trypsin activation drives recurrent acute pancreatitis, then chronic pancreatitis, then a lifetime pancreatic cancer risk that approaches 40 to 50% by age 70. That is the highest non-syndromic genetic pancreatic cancer risk in clinical practice. Smoking dramatically amplifies that risk on top of the genetic baseline. Annual EUS or MRI starts at age 40, and smoking cessation counseling is part of every single visit, because no other modifiable lever has the same magnitude of effect. Prophylactic total pancreatectomy with islet autotransplantation is rare and reserved for PRSS1 patients with high cumulative cancer risk plus intractable pain. In those patients, the cumulative damage from chronic pancreatitis and the cancer trajectory together justify removing the organ. The treatment side of this section ties back to mechanism through synthetic lethality, and this is now standard knowledge because germline panel testing at the time of pancreatic cancer diagnosis is standard of care. BRCA1, BRCA2, and PALB2 mutations impair homologous recombination, the high-fidelity pathway for repairing DNA double-strand breaks. Platinum chemotherapy creates DNA crosslinks that require homologous recombination for repair. So a tumor with biallelic loss of BRCA cannot repair the platinum-induced damage and dies preferentially compared to normal tissue. PARP inhibitors block the alternative pathway for single-strand break repair. A tumor that has lost homologous recombination and is now also denied PARP-mediated repair has neither double-strand break repair nor single-strand break repair available, and the unrepaired damage triggers preferential death. A randomized trial in patients with germline BRCA metastatic pancreatic cancer who had completed at least 16 weeks of first-line platinum-based chemotherapy without progression compared maintenance olaparib against placebo, and olaparib roughly doubled median progression-free survival. Olaparib is now FDA approved in this indication, and germline panel testing at the time of pancreatic cancer diagnosis is standard precisely because the result has direct therapeutic implications. Somatic BRCA or PALB2 mutations, identified on tumor sequencing, predict the same platinum benefit through the same synthetic lethality mechanism. That brings us to the section that ties the entire chapter together. Hereditary GI cancer syndromes require coordinated multi-organ care because no single specialist sees the whole picture. The dominant practical failure mode is not misdiagnosis. It is the confirmed carrier whose colonoscopy stays on schedule, but whose gynecologic, urologic, or dermatologic surveillance has lapsed for years. A confirmed Lynch carrier requires colonoscopy, urinalysis with cytology, and EGD with random gastric biopsies. The same carrier needs endometrial sampling, transvaginal ultrasound, dermatology, and prostate screening. And risk-reducing total hysterectomy with bilateral salpingo-oophorectomy belongs in the conversation after childbearing. That program runs across gastroenterology, gynecology, urology, dermatology, and surgical oncology. A Cowden carrier needs breast, thyroid, renal, endometrial, dermatologic, and GI components delivered across an even broader set of specialists. A CDH1 carrier needs immediate surgical and breast care from the moment the result returns. The board stem is a list of completed surveillance items, and the question is what is missing. Cascade testing of first-degree relatives of identified probands is the single highest-yield public health intervention in hereditary cancer prevention. It changes the cancer trajectory for the family more durably than any individual intervention in the proband. The yield is high because a confirmed pathogenic variant in the proband converts cascade testing from a probabilistic exercise to a targeted one. Without a proband result, testing a relative means running a full multi-gene panel for an unknown variant. With a proband result, testing a relative means single-site sequencing for the exact familial variant, which is faster, cheaper, more interpretable, and more actionable. A typical proband-positive family identifies several at-risk relatives who would otherwise have surfaced only after a sentinel cancer in the next generation. Cascade testing is the primary task in the months after a proband result returns, and the genetic counseling team is the infrastructure that makes it happen. Risk-reducing surgery decisions sit at the center of multi-organ coordination because the timing involves fertility, hormonal effects, surgical morbidity, and a surveillance program that continues afterward. Prophylactic total gastrectomy in CDH1 carriers is offered between 20 and 30. Risk-reducing total hysterectomy with bilateral salpingo-oophorectomy in Lynch is offered after childbearing because the trial data showed complete protection from endometrial and ovarian cancer in the prophylactic surgery arm. Risk-reducing bilateral mastectomy is offered in BRCA1, BRCA2, and CDH1 female carriers. Total proctocolectomy with ileal pouch anal anastomosis in FAP is timed to polyp burden and dysplasia, typically in the late teens to early 20s. Each surgery requires multidisciplinary discussion of the surveillance intensity that continues after surgery. Annual rectal surveillance continues after ileorectal anastomosis in FAP. Annual breast surveillance continues after risk-reducing oophorectomy in Lynch. Lifelong B12 and iron supplementation follow total gastrectomy in CDH1. Reproductive counseling extends the conversation into the next generation. Pre-implantation genetic testing for monogenic disorders is available for autosomal dominant syndromes including Lynch, FAP, Peutz-Jeghers, Cowden, hereditary diffuse gastric cancer, and hereditary breast and ovarian cancer. It allows carrier couples to select unaffected embryos at the time of in vitro fertilization. Prenatal diagnosis through chorionic villus sampling or amniocentesis is the alternative once pregnancy is established. This conversation belongs in the cascade testing visit because reproductive choices in young carriers run on a clock that intersects with surveillance decisions and risk-reducing surgery timing. Insurance protections are a separate counseling task that the boards test directly. The Genetic Information Non-Discrimination Act covers health insurance and employment-based discrimination based on genetic test results. GINA does not cover life insurance, disability insurance, or long-term care insurance. The boards test this distinction because patients and clinicians often assume GINA is comprehensive. The counseling implication is concrete. Cascade testing visits routinely include the recommendation that patients obtain life and disability insurance before testing if they do not already have it, because positive results can affect underwriting in those categories. A healthy 35-year-old whose mother carries a documented Lynch variant and who is shopping for term life and long-term care coverage is the classic vignette. That patient is asking for the counseling first, not for the test itself yet. Variants of uncertain significance are a recurring counseling challenge and a recurring board trap. AVUS is not actionable. It does not justify cascade testing of relatives. It does not justify gene-specific surveillance beyond what personal and family history would otherwise indicate. It is not a positive germline result. The surveillance program for a patient with a personal cancer history plus a VUS is anchored to that personal and family history, exactly as it would be without the test. VUS reclassification over time is common, most often to benign as population data accumulate, and patients should be recontacted for updated interpretation periodically. The common real-world error is telling a VUS carrier relative they have a Lynch mutation and entering them into Lynch surveillance. That is the wrong move, and the boards punish it. Pretest risk assessment uses validated tools. PREMM5 for Lynch, BOA-DCIA for hereditary breast and ovarian cancer, and PEN-II for Cowden are the names worth knowing. Pretest informed consent covers the implications of positive, negative, and uncertain results, plus the gene limitations. Multi-gene panel testing has largely supplanted single-gene testing because phenotypes overlap and panels capture rare or unsuspected mutations efficiently. Universal tumor-based screening of colorectal and endometrial cancers identifies probands who escape pedigree-based recognition, and tumor immunohistochemistry remains the entry point for the Lynch reflex covered in Episode 1 of this chapter. That brings the entire series to a single framework that runs across every hereditary GI cancer syndrome. Mutation drives risk. Risk drives surveillance. Family drives cascade. The germline change defines the mechanistic family, which defines the organs at risk, which defines the surveillance program, which is calibrated to the dwell time of detectable pre-invasive disease in each organ. Then the proband result converts cascade testing in relatives from a probabilistic exercise into a targeted one, and the family's cancer trajectory bends across the next generation. Every chapter in the series has been a variation on this logic. The colonoscopy-driven syndromes of FAP and Lynch led into Poitz-Jeghers and Cowden, and then into the hereditary gastric and pancreatic programs that close the chapter. You now have the toolkit for board prep, and you have it organized in a way that holds together when the STEM describes a syndrome you have never seen in clinic. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of Episode 5 of Chapter 36, and I'll see you in the next one.